Hello and welcome, everyone. Welcome to APTA's Academy of Leadership and Innovation podcast. I am so excited for today's conversation because honestly, this one has been on my heart for a while. My guest today is Katie, a physical therapist, a primary care PT, and someone who I believes represents exactly the kind of bold and unapologetic leadership that our profession needs more of right now. Katie's story is one of those that makes you sit up a little bit straighter, think a little bit about what is possible, not just in your career, but also the way you see yourself as a clinician. So, Katie, I'm going to let you take it from here. Let's have you introduce yourself and tell our listeners who you are and what is it exactly that you do.
Well, thank you so much for having me on the show. What an introduction. I like some of the adjectives, bold, unapologetic. That seems to sort of fit the bill. So, again, thanks for having me. My name is Katie Obright, and I am the owner of Redefine Health Education, which I started this company with the mission of getting APT in every primary care clinic in the United States and in the world. I think that we need that kind of access, and the only way that we're going to make it happen is by showing up and by demonstrating our value in that space. So I started my career in the Army. My first job was in a soldier-centered medical home, which was soldier primary care. And when I figured out what right looks like by serving in that capacity, as soon as I got out of the Army, I thought this is something that needs to be mainstream across the board. And I'm here trying to make that happen.
Thank you for sharing that. And I love how you said you want a primary care PT, not just in the US, but everywhere across the globe. I love that you're thinking about the big picture.
Well, what's interesting is the big picture actually we're behind the curve at this point. In fact, globally, there are more PTs embedded in primary care pathways globally than there are in the United States, and that really is a sad thing because we are once again behind the curve and lagging behind what other countries are doing and finding effective, cost effective, and improving accessibility and outcomes for patients.
Thank you for sharing that. I think that's a very interesting point that you raised. I'm curious to know, based on your experience of having done this for so many years, what do you think is the reason for that? Why do you think that we are behind the curve? And what do you think we as a profession need to do so that we are not behind the curve?
I think that the older I get, so I'm not that old, I'm only 36, but the older I get, the more I am realizing that the United States has an interesting culture that is a lot less progressive than most of the world. And the fundamental conversation revolves around money, as it does with everything, right? So, like, our payment system for healthcare in the United States is one that it has an absolute dichotomy where the third party payers are trying to make as much profit as they possibly can and contain as much cost as they possibly can. The hospital systems and the healthcare organizations are trying to drive as much revenue as they possibly can. And the healthcare provider in the middle is simply trying to do what's right for the patient. And so we really don't have the best system to provide value to populations. However, I do actually think that in 2026 and beyond that this year has been such a pivotal year already, and I do really feel like it is going to shift. And if it doesn't shift in our favor, it's because we're not putting ourselves in that position in the PT industry as a whole. But to answer your question, why are we lagging behind other countries? It revolves around payment and finances.
I agree with you. Thank you for sharing that.
Mhm.
So, walk us through your journey into primary care PT. What drew you to this area of specialty and how did you get here?
Yeah, when I arrived at my first duty station, I graduated in 2014, and my first boss at Fort Sill, Oklahoma said, "Okay, you're going to go into primary care." And I said, "Okay, like what am I going to do there?" So I came out of PT school having already had several military clinical rotations under my belt. So I kind of knew what I was getting into. I knew I was getting into a space where I was going to be serving as more of a population health manager and doing primarily evaluations, less follow-ups, only maintaining, the patients that really had more complex needs and higher acuity. And so when I got into this role, this was the first time I had ever heard of the PT actually embedding within a primary care clinic. And as soon as I started in that role, I very quickly realized how much of an asset that was. The reason that the Army did it in the first place is because they had such a problem with backlogs in referrals to primary care. When you work in a single payer system like the military, like the VA, like other countries, you run into problems with volume and you have to be more efficient about and judicious about your use of services. And so what they were seeing was this really high volume of musculoskeletal issues that required a PT's expertise. And so they would have these major backlogs in wait times to get into PT, sometimes upwards of 2, 3 months, which is like at that point, you're affecting the readiness of the military and you really need to fix that. So by moving PTs into primary care, they were able to better identify which soldiers actually needed just a little bit of care, some self-management. What they needed was better and more accurate diagnosis and care navigation for soldiers that did not need traditional rehab, higher frequency rehab. And so moving into that space, I very quickly saw the value in it and how much it helped get soldiers the care that they needed faster. And I also learned how amazing it was to be in the same work setting as other healthcare professionals, how much I learned from them, how much they learned from me, how collaboratively we worked together, while, respecting each other's space and expertise. It was awesome. And when I got out of that, I and then just kind of like seeing what mainstream healthcare and mainstream PT is like. It's so fragmented, it's so siloed. We've been talking about this for decades. And there's only at this point, 2026. So I've been out of the Army for 8 years now. And in 2026, we're still not seeing it really take hold. And I think that it needs to be on the minds of every single healthcare operator in the country if we're actually going to make it move. We have these clinicians, kind of like staff level clinicians that are like, yes, I want to do this job. This is exactly what I want to do. But if it's not going to make any movement at the operational level, then nothing is going to change and this model of care will never be adopted. So that's the impact that I am looking to change.
I love that. And I love your response because I think a lot of times we forget the impact that we can make in our patients' lives, right? If a soldier is not doing well and if they can't go and serve the country, that's going to impact all of us. So I think the little things that we do actually have ripple effects and it can make a huge difference.
Absolutely.
Yeah. So I'm curious to understand how would you describe a typical day in the life of a primary care PT to somebody who's never heard of this role before? And
hmm
how is it different from what a traditional physical therapist does?
Okay. That's a really good question. And I would have answered this question differently 1 year ago than I do today. And that's because of how quickly AI augmentation and streamlining is taking effect. And I've been following that very closely. And I think it's going to be revolutionary. So, at this point right now, when you think about a traditional outpatient physical therapist, and I will be primarily referring to outpatient because when we talk about primary care exists in the outpatient world.
Very true.
So, sure, there's some continuity of care and stuff when somebody's in the hospital and then they're discharged, but ultimately, we're talking about the outpatient environment. And we're also not talking about the emergency care environment. And I'll talk about that a little bit later. So, in primary care right now, or excuse me, in physical therapy right now, most patients are still accessing physical therapy by a referral. Referral comes in, patient is, called and scheduled, and then the patient comes in, they do an initial evaluation, they set a quote plan of care, and then they come in for pretty high frequency, in my opinion, pretty high frequency treatment visits, usually about 2 times a week for 6 to 8 weeks. And that is kind of the bread and butter, cookie cutter response to what PT is If you ask any patient, if you ask any payer, if you ask any physician what they think physical therapy is, they're probably going to come up with an answer like that. But should it be that way? And should it be that way for every patient that comes in the door? And my answer to that is not no, but heck no. And here's why. The vast majority of patients that could benefit from engaging with a physical therapist, notice how I said it that way instead of physical therapy. The vast majority of patients who could benefit from engaging with a physical therapist never end up seeing a physical therapist for all of the reasons that I just mentioned. It's a referral, it's an additional cost, and it's high frequency, which a lot of people just do not have a lot of time for. And so when you get into that space, when there's about 90% of patients out there that really could benefit from engaging with us, even just one time, they're never even seeing us. If you start to change that model where 90% of those patients now can access us, we cannot see 1 to 2 evals a day.
Right.
We cannot be keeping every single patient 2 to 3 times a week for 6 to 8 weeks. It doesn't work. It's not efficient. It's not cost effective.
Right.
And then payers don't see the value or anything like that. And so what a primary care PT would be doing at this point, a day in the life, would be something along the lines of, they arrive to work, and maybe it's something where they do a little bit of time in telehealth, and then they do a little bit of time embedded in primary care, or maybe they're even kind of in the PT clinic themselves. But really, the model works best when you do have that intentional co-location between a physical therapist and the rest of a primary care team. So a day in the life would look like you arrive to work, you have about 20 minutes where you can discuss the cases that are on your schedule for the day with your PTA, with the nursing staff. You do a huddle. And that huddle is to ensure that everybody on the team knows their role, knows what needs to happen, and knows, how the day ultimately is going to go. You talk about specific patients that are coming in. Oh, this patient is going to require a little bit more complexity. So maybe we want to have that patient see their physician first, and then we'll see them. And so it ends up being a whole lot more efficient that way because you can utilize your PTA for some basic intake and testing. If you know a patient is returning to see you for a particular reason, or if you know a patient is coming in for a certain reason, you can sort of get the ball rolling with some of your support staff and your assistant in order to get things moving in the right direction. So by the time that you get in with a patient, you're doing the high level, high skilled doctoring things that you know how to do that the PTA and the other staff do not. And so when consults come in, and this can be through a schedule, it can also be through, you can have sort of an open schedule where physicians that you're working with can provide warm handoffs to you. Let's say somebody comes in for a blood pressure check and all of a sudden they start talking about dizziness. You can do your dizziness screening with that patient, and it's a warm handoff. They say, "Hey, I've got this patient in room 9. They've got this going on. Can you just screen them and for like do your whole dizziness workup?" Great. Go in there, do your dizziness workup, and that ends up being the session that you are with them. It's not PT a PT evaluation in a traditional sense where you do everything exclusively by yourself and you do the full battery of testing, everything that needs to be included. You are still conducting your evaluation. I'll be clear about that. You are still conducting your PT evaluation and still doing your own note, but it ends up being a whole lot more streamlined, and you then become the care navigator as opposed to just the treater or the rehabber, if you will. So maybe that patient doesn't even need your services. Maybe they were dizzy because their new blood pressure medication is actually making it that way. And their primary care physician just wanted to make sure that they weren't experiencing a vestibular issue at the same time. So you become this really high level, valuable asset in primary care when you serve in that capacity. So, In that sense, you are seeing more initial consults for probably a shorter period of time. And yeah, that sends PTs flying and never want to do anything. But I promise you that when you learn how to work in a more efficient environment where you have more assistance and you're able to delegate and work in a team in a better way, all of this becomes much simpler and it's much better for the PT that really wants to do this kind of diagnostic and management care work.
I love that. And it sounds like there are so many different roles we play over here, right? One looks like, of course, you're playing the role of a physical therapist, but then you also have to triage. You also have to be good at collaborating, making quick decisions. I think my next question comes from a student's perspective. So if there's any student listening to this, I'm curious to understand, is the standard doctor of physical therapy education enough to practice in a primary care physical therapy, like enough to practice in a primary care PT model? Or do you feel like we as a profession need to train ourselves a little bit more or improve our skills? And if yes, what do you think people who are interested in getting into, pursuing this path, what do you think they should focus on?
I think that's a really good question to then ask back to each individual student. What do they feel that they're ready for? Because I, as a new grad, went directly into a primary care setting. And did I have questions? Oh, yeah. But every time I had a question, I had somebody to go to when I had a question. But I still was able to jump into that role and I liked it and I was excited about it. I think there are other student physical therapists and new grads that come out that actually would prefer to be in a more focused specialty area. So, what I'm going to do is I'm actually going to read verbatim, it's just like a couple sentences, what the primary care PT consensus definition was just released last week. So now we're in April, what day is it? April 14th of 26,
That's
just
perfect.
released last week. And this actually includes a segment on education, competency, clinical privileges, and specialty. And so the education section says entry level education for doctors of physical therapy includes training in medical screening, differential diagnosis, management planning, and health promotion in all physical therapy practice areas. Primary care PT residency programs currently in development and other forms of post professional education and mentorship may foster competency advancement in this practice area, and that the opportunity is there for formal demonstration of competency with a primary care PT board certification. However, it does not preclude a new grad from entering into this space. And I think there are some bomb new grads who can jump right into it, but it has to be right for you. It's just kind of like, when you're making the decision of like, oh, I really want to be an ortho specialist, or I really want to do pelvic health, or I really want to do like inpatient neuro. This is another area that's like, oh, I really want to do primary care. I kind of want to be there right when it's first starting. I want to be there on a team. I want to do that kind of work. So it's kind of that kind of decision that would drive like a new grad's decision of like, do they want to do it or not?
I agree. And thank you for sharing that statement. That's good to know. And I was just gonna say, I think the timing is perfect. We're doing this podcast today, and the statement was just released of just last week.
Mhm.
And I agree with you. I think there are some new grads who are excellent, and they are if this is an area of interest for them, I think they should definitely pursue it. So for them, what do you think if there's a new grad listening to you right now, what advice do you have for them? What should they be doing right now? Maybe they're in their third year of PT school, or maybe they're a fresh grad. Is there anything specific that they should be focusing on if their goal is to get into primary care in the next few months or in the next year or two?
I think that they should get involved in primary care. So that's the number one. You have to understand how a primary care clinic functions, and you have to understand what it's like to work in a clinic with other healthcare professionals that are not PTs. You got to understand the culture, the workflow, the just kind of the day to day and how it all works because it is different than PT. It's faster paced. There's more patients that are going to be coming in at any given time. And you have to be highly flexible and adaptive. You can't be very rigid. You can't expect the same schedule every single day. You can expect some kind of consistency in your workflow, but I think the bottom line with that is get experience in a primary care clinic, just shadowing if you can. If you can do a clinical rotation, that would be awesome. I know there's more and more clinical rotations that are becoming an option.
Right.
And the last thing that I will say is to work in this role, you have to be totally fine with uncertainty. Because
True.
the first time that a patient comes in, sometimes you only have, 15 to 20 minutes to just gather information from them. And you do not have to have a full package plan of care tied up with a pretty bow in a traditional sense, like you would in outpatient ortho. You don't have to have that in primary care. The plan of care in the first time, if you have uncertainty or if they need additional diagnostics in order to refine your diagnostic hypothesis, your initial plan of care is they need this study, they need to go see this specialist, we need to start with this home care program, and then the ultimate answer is watchful waiting, return in 2 weeks, and then we'll reassess. And then at that reassessment, that ends up becoming like, okay, now we have more information, let's sort of continue on. And I think that PTs think that everything has to be answered in that initial evaluation. And the reality is that's like almost never the case. It's an diagnosis is an evolving process that sometimes takes months to declare itself. And going through rehab and going through the interventions that we have, the education, the exercise routine, the activity modification that we provide, all of that actually contributes to your diagnosis. The response to the patient's care contributes to that. So I think that thinking about it in that sense and being very comfortable with uncertainty is something that every new grad working in this space or anybody working in this space should be real or get real comfortable with real quick.
True. I agree with you. I think shadowing people who are already working in a primary care setting or talking to somebody who is in this space is definitely a good start. And if students want to shadow, I'm guessing the military, VA, integrated healthcare systems are good places to look into.
I actually disagree with that, and here's why.
Interesting.
I have been very intentional about not including the military and the VA in a lot of my work as of late because it just great. Like, so what? So what? Everybody knows that the military and the VA are progressive and that they allow all this stuff and yada yada. It
Right.
doesn't matter though if it can't apply to you. And so,
Mm.
what I would encourage people to do actually is wherever you think you're going to end up, you're going back to your hometown, you're going to stay where your university is, find a primary care clinic there. Leverage the health system where you already have a clinical rotation and just tell your clinical instructors, I'd really like to do a day shadowing in primary care. That is so much simpler to do when you're already a student or a resident. It's so much simpler for you to do that than for like me as an outsider trying to be like, oh, I'm already a PT. Can I come shadow you for a day? And they're like, we just want to work with students. So I actually think that if we're gonna make this impactful on a large scale in the United States healthcare system, we have to start doing it in primary care clinics where this model may not exist yet.
Right.
And we need the next generation of PTs to start making moves about how our value can impact their bottom line, how it can address their pain points in primary care, because that's what's going to make them want us to keep coming back.
That's fantastic. Thank you for sharing that. I think that's a really good perspective. Like we don't have to wait. You can just go knock on the door and ask
Please, please go knock on the door.
to be the trailblazer, right?
Hmm.
Talking about, I know we've been talking about this from a student's perspective. Let's talk about a clinician who's been in the profession for a while.
Hmm.
So, I mean, I know burnout is such a common topic these days. I think it's one of the most commonly spoken about things. There are a lot of seasoned physical therapists out there who feel disillusioned. They feel burnt out by the system. They feel undervalued, questioning why they even chose this path. There are a lot of Facebook groups and social media groups where if any student asks if they should pursue physical therapy, there are a lot of experienced clinicians saying, think twice before you do that. What
Hmm.
would you say to that clinician specifically, not the new grad, but the one who's been grinding for 15 years and has lost the fire within them?
What's their source of burnout? That would be my first question. And I think that the source of burnout is the increasing pressure, the increasing productivity requirements, see more patients, do more documentation. And oh, by the way, do that in your off time too, because we're not going to pay you for it. They have every right to feel that their profession has done them a disservice because in those circumstances, it has. There are some of my colleagues who have not seen a pay raise in like 10 years. That's unacceptable. That's unacceptable as an industry. It's unacceptable and it's unsustainable to our industry. They have every right to feel that way. And so, what I would say to them is if that is the model that has bogged you down, you have every reason to buy into this model so much more. And here's why. This is sad to say, but I have had better success discussing the value of this model and actually taking actionable steps to move forward with it. I've had an easier time explaining that to physicians and primary care groups than I have to physical therapy organizations.
Wow.
That's sad.
That
That's
is,
sad. And that to me is just a sign of we're just kind of stuck in our ways. We're not going to evolve. It's too high risk. We're not going to do that. Um, and and at this point, I'm kind of saying, all right, well, I keep saying this same phrase. This is where Netflix takes over Blockbuster. And so all of these, there were companies, healthcare companies on the market that were going nuts in like the early 2000s that are no longer here. And say like if you just look at the way that businesses evolve over time, there are really big changes in the landscape and in the payment environment and in the culture and just in the times that precipitate one company just kind of becoming obsolete, being rendered obsolete, and another company rising up. And so we've already seen this, right? Over the last 5 years, we've seen Hinge Health and Sword Health kind of take over the direct to employer market.
yeah.
And is that PT led? I mean, there's PTs on staff, but I don't know that those are not PT led companies. Um, but guess what? They're showing signs of success. And meanwhile, we have a lot of other major corporations that have, gone public and then gone private. And then other companies that like they're really not showing reasonable and sustainable business returns. And so when I look at that as a whole, I really think that we're at a pivotal time right now where we either need to adapt how we do things or we have the chance at perishing. And so when I'm talking about the direct clinician, your question was about burnout. Staff clinicians have every right to feel that way.
Right.
I think that there are more, and I hope that there are more staff clinicians that actually say, I'm not doing this crap anymore. I want to do things differently that will actually start to be, the engine behind driving change in new industry innovation. And there's so many different pathways to follow in that. The Medicare payer models that are coming out in 2026 are supportive of this. But we just have to actually get involved in those conversations and being a part of it so that employers of physical therapists can give them an opportunity to utilize the skills that they already have. I have a paper here. It was a 2022 paper by Burri, and colleagues on contributions to PT burnout. And there's like this, list of like 15 different things. But one of the top five, level of financial satisfaction. So that's a problem. And we need to find ways to improve. And guess what, guys? It's not going to be in the fee-for-service system. The fee-for-service system is being intentionally and systematically adjusted so that they pull money away from specialty care, which PT is still considered specialty care. It shouldn't be, but it is. And they're dumping it back into primary care. Whenever Medicare makes movements with fee-for-service system, they take piles of money out of one bucket, they put it into another because they have to maintain this. It's the Balanced Budget Act, right? So, level of financial satisfaction. So, we have options here with the new value-based programs. There are more sustainable revenue structures with where we embed in primary care to make it better in the future. The fee-for-service system will still be there. It's not going to magically change where we can adequately support the salaries of PTs as inflation continues to be driven. High workload. So yeah, we have insanely high workload and nobody should be taking work home in their off time. That's contributor number one to burnout. Unsatisfactory organizational structure, policies, and administration. That's number three. And that comes down to like you're a staff PT, you have no say in what your company is doing whatsoever. You have no idea what they're even planning, what they're doing. There's a total top-down, okay, we're going to start doing this. Now every provider has to follow suit. And the expectations are a little bit out of alignment. Working hours, so that's another thing. And then the fifth thing is underutilization of skills and issues with autonomy. So when you go to school to be a doctor of physical therapy, is your employer expecting that you're going to practice like a doctor, or are they expecting you to practice like a technician in a model that was built in the 1970s? We have every opportunity in this industry to change it. It's just a matter of people actually making those moves. And I think that all of this PT drop off after 2 to 3 years of practice is going to drive those changes.
Mm. That is true. I think the pendulum is swinging in the other direction. So
I
it's
I I do I hope so.
yeah. Um, Thank you for sharing that, and thank you for sharing the reference as well. And I agree with you. I think when we talk about burnout, it's not just one thing. It's always multifactorial. And we need to, if we want to really address that, I think we need to address it from all different fronts to make a real
Absolutely.
difference. Um, you mentioned that as a primary care PT, you have to collaborate with different clinicians, physicians, NPs, so on and so forth. Physical therapy is a very women-led profession. It's a very women-dominant profession. Other medical professions may or may not be that way. So, my next question to you is, as a woman in this space, did you feel the pressure to shrink, to not push hard, to not ask for too much, to not take up too much room? So think about a situation where maybe you disagreed with what a physician or what the NP thought. How did you manage that? And what advice do you have for women listening to this conversation?
I have to slow down here because if I jump to my immediate answer, it's not going to sound right. Um, First, I'll talk about the gender piece. The that to me in my mind doesn't even exist anymore. And here's why. Well, there's a lot of reasons why I've kind of been that way my entire life. I think I was kind of raised in a household where like, very, very traditional. I'll just put it that way. Katie is not a traditional kind of woman. And so there's a reason why I was the first one at age 17 to sign on the dotted line to join the army, you know, and it's because I wanted to prove that I could do everything that a man could do just as well. And I think that that has carried through in a lot of other facets of my life. So if that just gives you a glimpse about what my answer could be here,
Fair enough.
then that's it. So another thing too is like at this point now, undergraduate education is actually more, there are more undergraduate degree holders, people who have graduated from, bachelor's level degrees who are women. So it's like 60% of enrolled undergraduate, and I can find the reference for that. It was actually from a Freakonomics podcast, if anybody listens to that. There's 60% that are women. And so we have more women who are opting to go through and get an education than men. Same thing in the physician workforce, like it's 50-50 men to women. So we don't have this issue of gender anymore. And if it's there, it's not gender, it's just the person. And so what I want to encourage everybody, no, I have never like shrunk because I'm a PT and someone else is a physician. It's not a thing. I'm a PT and they're a physician and we work together. We're a part of a team. We're colleagues that have completely different scopes of practice. that complement each other and we serve the same patients. That's
Right.
it. If I get something, this happens in the PT industry all the time. You get a referral that says Morton's neuroma, and you're like, ha, it's not a Morton's neuroma. Like, and it doesn't even like follow the pathway of what a Morton neuroma would look like. There's no numbness and tingling. Like, come on. And so they're just like throwing labels on it because they may or may not know.
What's happening? True.
Now, is that something that we go back to them and we're like, oh, you're wrong. That's that's not good diplomacy. It's not good collegial communication. Even if would you appreciate if somebody came to you and said that? No. It's more about just a conversation. Hey, I noticed that this patient has some signs and symptoms of this. It doesn't really seem like it's consistent with a Morton's neuroma. I'm actually seeing more problems with the MTP joint. This is what I think needs to happen. This is my plan. And, do you have any other comments? We don't need anybody's permission to move forward. Like, per insurance, we might need a signature on a plan of care, but we all know that those signatures are coming from the physician's MA that's literally writing signature, putting the stamp on every single one of the PT plans of care that are coming through. It's an administrative barrier that for some reason CMS is still pushing, and I can see it changing in the near future. So no, being a woman in this space, I think is a powerful thing. I think that I don't see the difference between me being a woman and them being a man. Sometimes where I do see it, I'll call it out and I'll opt not to work with those individuals because if it's overtly clear that that's something that's still in existence in 2026, like no, hard no, pass, bye, done. And so if anybody ever comes into that kind of thing, that's exactly the pathway that you should follow. But again, sometimes there are certain people that you need to continue to work with. And sometimes it is better. And this is third decade Katie Obright compared to second decade Katie Obright. Sometimes it's better to hold back and kill people with kindness and keep them as just a part of your team because that's your overall strategy and you're working smarter than them than it is to like completely burn a bridge or walk away. So you have to know when it's the right time to do that. For example, if you get embedded in a primary care clinic and there's some hothead physician that thinks that they know everything, or if a physician, PA, whoever it is, even a medic, a nurse, sometimes it's the nurses that are like, they run the show in primary care. And sometimes it's them that you got to convince that like you're actually a part of the team. So whoever it is all about the psychologic profile of the whole situation. And you have to be the one who works within that diplomatically instead of coming in hard charging like you're going to change the world and you want them to change this and that. That's not going to get you anywhere.
Yeah.
So that's what I have to say about those pieces.
Love that. I love that response.
You have to be confident, though. If you are coming into a
That is
space
true.
and you're going to be a subject matter expert, which you are in your space, you have to come in confident and competent. You know what you're talking about. Be confident about how you're communicating those things. And also be confident about when you're not sure. And you can
Right.
say, you know what, there's a lot of uncertainty that's still here. Here's what I'm going to do about it. Here's
Right.
my plan. My plan is we're going to try this for 2 weeks. We're going to see what the response to care is. That's going to give us even more information. And then we're going to come back and see what the next steps are. When
True.
you can confidently explain uncertainty to another healthcare professional and to a patient, man, you're doing something right
True. And you're making the real difference, right?
for sure.
That was amazing. Thank you for sharing that. That actually brings me to our last question today. Is there anything that we haven't discussed, but you feel like you'd want to share with the world or whoever is listening to you right now?
I see the same things that you do on social media where people are actively looking to leave the industry. And it's not just PT. That's the one thing I really want to highlight. It is across the board. Physicians are tired. They're not wanting to deal with this massive system. It is not going in a good direction. However, movement into innovative territory within healthcare is something that is being promoted and supported. And with all of the changes in AI right now, what AI can do for us in our practice, it's going to transform. And
Right.
if we are able to be a part of the change instead of just remaining as a cog in the wheel,
Yeah.
then I would encourage anybody who is able to realistically and financially, get out of their existing job and start in something else and start trending down a different pathway. I would encourage anybody to start heading that direction because there is a lot of reward in that space. There's been $10 billion invested into AI augmented tools for healthcare in just the last few years. There is massive change coming our way in the next 5 years. And I really do feel like this is a pivotal moment. So for those that are tired and burnt out and want to get out of it and or really just want to find strategies to innovate and to make our healthcare system work better for the patients that we serve and for ourselves,
Right.
then you have there are major opportunities right now to be a part of that. So I would encourage anybody who's kind of feeling that lull to just kind of start digging into health tech and start digging into some of these new Medicare programs like the LEAD program, like the Access program, the ambulatory specialty model. There are lots of different new value-based programs that are coming out. And oh, by the way, that the bundled joint replacement, Medicare just revamped that and like made it even more robust. And so if we are not, if as physical therapists, if we're downstream and we're not a part of those upstream conversations, we will be left out. We
Right.
will be the industry that just kind of rides on the coattails of everybody else that's doing everything. But if we can get more PTs to engage in those conversations and really have an understanding about what's going on, there's major opportunity there.
I agree. That was very insightful. Thank you for sharing that.
Mhm.
Katie, it's been a pleasure having you on the podcast today. I knew this conversation was going to be good, but honestly, you exceeded all the expectations. I think what struck me the most today was that your story is not just about primary care. I think it's more than that. It's about believing in yourself, not being afraid, making sure you're being courageous, and not letting anybody tell you that you belong here or you don't belong here. So thank you for sharing all of your insights and your experience. To our audience, I just want to say Katie's information is going to be in the show notes, and we'd love to hear what resonated with you the most. This has been APTA Academy of Leadership and Innovations podcast. And until next time, be bold, be curious, and never stop leading. Thank you.